Rosenzweig, and I've had ALK for 12 years, and I'm a patient like you. And every other Sunday or so, we get together and get some knowledge and learn some new things and ask questions to experts. And Laura Petrillo, Dr. Petrillo, has been with us. This was her second time. She came in 2022. She was a rock star at our 2022 virtual summit and did a wonderful job. So thank you for joining us, Dr. Petrillo. And I want to start with some polling questions first. And, I always screw up our polling questions for some reason. Okay, hopefully these launch. When were you diagnosed? This is also for Dr. Petrillo to know who's in the audience. Share the results. Summer, take it away.
Okay, when were you diagnosed? 9% of you under a year, 6% of you 1 to 2 years, 14% of you 2 to 3 years, 17% of you 3 to 4 years, another 17%, 4 to 5 years. That's me. 9% of you are 5 to 6 years, 11% of you are 6 to 7 years, 9% of you are 7 to 8 years, 3% of you are 8 to 9 years, and 6% of you are 10 years or more. Thank you so much for joining us tonight.
Okay, we're going to jump into our next question. What is your current treatment? There are a lot of different treatments. So, and guess what? Every year we get more. And we're very, very lucky and fortunate. And share your results. Summer.
Okay, we had a lot of options today. So what is your current treatment? No one is on crizotinib or ceritinib, but sometimes people are, so we did want to include that. 7% of you plus myself are on brigatinib. 59% of you are on alectinib. 29% of you are on lorlatinib. 2% of you are on chemo with the TKI. No one is on chemo only. We don't have anybody here that's on the gilteritinib trial. No one on the Nuvalent trial, except that's not true because Mark actually is. We don't have anybody in general on a clinical trial. 2% of you, this is not applicable, so maybe you are a caregiver or someone else, and no one that is not on any treatment at all. So thank you.
Yeah, it's possible that maybe some people just jumped on for fun. So.
Oh, we are pretty fun, so.
Our palliative care questions and popping up for some reason. So I'm going to wing it for a second. Our healing arts programs, which I counted, we only have like 7 days where we don't have a program out of the whole month. Dana Credo runs that program. And I want to say that you can jump on that, ALKpositive.org. And on the top, you can see ALKtALK. Hit that, you'll see our calendar. And I'll pass over to Summer.
Thank you so much, Mark. That other question was just to gauge, to give us an idea of your knowledge about palliative care. What are you thinking when you hear the words palliative care? I was actually pretty shocked. About a month ago, someone wrote in the support group about they had progression and they were getting a biopsy and seeing what was next. And they were very symptomatic, but they thought they had some options. And I said, oh, I'm so sorry to hear you are suffering. Maybe add a palliative care physician to your care team. And the person who is so knowledgeable did say, no, Summer, stop. I don't think I'm at that point yet. And it was somebody that I looked to for advice. So I was actually taken back because palliative care is about living. And that is why Dr. Petrillo is here with us today. It's about buying the shoes. It's about planning the vacation, whether it's emotional support, financial support, physical, symptomatic support. It's not simply end of life, although believe me, I've been in that boat and was panicked the first time it was recommended to me. So again, knowledge is power, and that is why we are so fortunate to have Dr. Petrillo with us again tonight. She's a physician and researcher at Massachusetts General Hospital. She teaches at Harvard Medical School. And she is here to debunk the misconceptions of palliative care. So thank you so much, Dr. Petrillo, for joining us.
Absolutely. And I have some slides, but please feel free to jump in. I don't know that I'm going to be watching the chat, so if there is a question in the chat, please just shout it out to me. But thank you so much for having me. So as Summer and Mark mentioned, I'm a palliative care doctor at Mass General Hospital. So I see patients in the clinic who have all kinds of cancer, but including lung cancer. And my research is focused on lung cancer. And as you're probably aware, Mass General is a place where we get tons of referrals for people with lung cancer with targetable mutations. So I see that a lot in my clinical practice, and my research is focused on it. So this is an area that's very dear to my heart. I was mentioning to everyone before you all joined that I just am so appreciative of the advocacy groups and the information, support, and everything that you provide to each other, and frequently refer my patients to advocacy groups to make sure that they're connected, because I just think it's so important. Some of you, I see some familiar faces. Some of you may have seen these slides before, so apologies if it's a repetition, but we can, like I said, we can go in whatever direction would be helpful for you to learn about palliative care. So I'm going to go ahead and start sharing. Okay, great. So I'm going to be talking about what is palliative care, but like I said, happy to take any questions or field any thoughts that you might have about palliative care. So I'm just going to start with a definition, and this is the definition that I share with all of my patients the first time I meet them. Palliative care is a type of specialized medical care for people living with serious illness, not just cancer, but any serious illness, and it's appropriate at any age and any stage of illness. It's focused on providing relief from the symptoms and stress of the illness, and the goal is to improve quality of life for the patient and family. This definition is really important. It was arrived at by the Center to Advance Palliative Care through a process of market research, just to see what terms resonated with people because of how much stigma and misunderstanding there is about palliative care. But all of it is completely true. It is for people living with serious illness like advanced cancer, appropriate at any age and any stage. So I do see people with early stage cancer who have symptoms that need help with management. And I think that all people in medicine, I think ultimately are trying to improve quality of life, but often are very focused on survival, focused on specific diseases, focused on specific, we get kind of taught to learn about pathology in medicine. And so we focus on things that are going wrong. And in palliative care, we really try and focus on quality of life. And so that means when I'm treating people with cancer, it means that the oncologist is managing the cancer and is prescribing the anti-cancer medicine. And then anything else, any other way that somebody's life is impacted by cancer, I try and learn about that and try and help be an extra layer of support to help with improving quality of life. And so that might mean symptom management, things like pain, nausea, fatigue. It might mean psychosocial support, so support for coping with cancer. And it might mean supporting someone's illness understanding. So finding out what questions they have, and not just questions about how long they have, but it might be questions about how things are going to change with their illness, or what options might be coming down the pike, and then supporting people in making decisions. And this doesn't necessarily mean a decision about starting or stopping treatment. It might mean choosing among treatments, or choosing whether to take a pause and come back. And sometimes it seems like the decisions might all be straightforward, but there are so many nuances because people are so individual. So this is one of my favorite parts of my job, actually, is kind of like walking with people, getting to know them and what their goals and values are, and then being their advocate when it comes to making difficult decisions. We do help people with transitions in care. I noticed that you had a no treatment option, but sometimes when we have somebody who's not on cancer-directed therapy, but is still in our care, we talk about best supportive care being the option there. And so we might talk about help support someone in making a decision from cancer-directed therapy to supportive care as the main focus. And then we do also help with spiritual and cultural aspects of care. I want to emphasize that idea that Summer said so beautifully about how palliative care helps people live well, as opposed to focused on the dying part. This is one example of someone who I believe had multiple myeloma and was telling their story for the Center of Advanced Palliative Care. They had a blog and they have a website called getpalliativecare.com. She was talking about how neuropathy had affected her hands or feet and how that was how she made money. And then when she was in pain, she shut herself out and stayed in her room. And the palliative care team included me in the conference in terms of the medication, how I'm sleeping, how's my quality of life. And I would not be back sitting in this chair if it wasn't for the palliative care program. I'd be lost. I feel like I'm in the driver's seat because they're concerned about how I feel. And to me, that's about living. That's about what's important to you. What do you want to get back to? How can we help? And I think a lot of times people don't know. I remember I was at I don't think it was this one, but it might have been another meeting. And someone said, I didn't realize that I could bring up what was going on with my joints to my medical team. And it was like, this might be connected to what the cancer treatment you're receiving. And even if it isn't, if it's affecting your quality of life, I'll often make referrals to specialists, or you refer somebody back to their primary care doctor if it's outside of the purview of the oncology team or our team. But we're really focused on, we want to know everything, how you're eating, how you're sleeping, how you're going to the bathroom. We talk about all of it and try and make sure that everything is optimized so that people can feel as well as possible when they're going through cancer treatment. And I do want to acknowledge, though, I do not want to ignore the fact that palliative care did not start out like this. And there's like how we got here. I'm happy to talk through how we kind of got here and the perceptions of what palliative care is and what we do. So we're going to rewind. And I'm going to acknowledge the history. So the palliative care field of medicine, like the idea of getting really, of having doctors and nurses and specialists who are focused on symptom management, came from caring for people who are dying. And so all the way back in actually, when you think about medicine and how long medicine is around, this is not that long ago, but it was in the 1940s that this field was sort of born, and it was in the setting of hospices. And it was when people who would get cancer treatment got to the end of the line of their cancer treatment and then found that they couldn't find doctors to take care of them. They were sort of like left to be on their own. And so Dame Cicely Saunders, who's like the grandmother of our field, founded a hospice in London and became an expert in managing pain and symptoms and caring for families and doing really holistic care, and opened the first kind of brick and mortar hospice. I mean, attending to people and their suffering is like ancient, but this idea of having a really specialized place for people at the very end of life was a hospice, and palliative care was the name of the medicine that was provided. And that came over to the US in the 1960s. And then palliative care teams began to appear in hospitals, mostly for people who were hospitalized in the 1990s and the 2000s. And then there was a huge expansion in palliative care in the hospital. But it became really clear that it makes no sense to wait until somebody is at the end of life to focus on symptoms, to focus on quality of life, and to focus on alleviating suffering. And so this is just illustrating that idea that the initial focus was like cancer-focused care, focus on quantity of life, and then quality of life in the very last moments. This was the kind of original model. But then a huge turning point came in 2010, when there was a New England Journal paper from my research mentor, Jennifer Temmel. This was like the paper that was heard around the world, and it was early palliative care for people with metastatic non-small cell lung cancer. And the goal of the study was to compare the idea of integrating palliative care from the time of diagnosis for people with advanced lung cancer to usual care. And what they wanted to see was, does it help, you know, rather than waiting until somebody is so sick and they're done with their cancer treatment, does it help to have somebody check in from the time of diagnosis with people and ask them, how are you doing with your pain and your symptoms? Because we know that people with lung cancer are symptomatic when they are diagnosed from their cancer. And then we know that at that time, you know, this was 2010. So, you know, 2008, 2009, people were getting a lot of chemotherapy. And we knew that people were really symptomatic from their cancer treatment side effects. And so helping people with their symptoms, helping people with their side effects, and helping people with understanding what to expect and kind of coping with what was going on in their lives and helping their families. That was a resoundingly positive trial. It helped people improve their quality of life, which was the main endpoint. And that was a major finding. It also improved mood, so people had less depression when they had this attention to quality of life from the time of diagnosis. People had greater understanding about the goal of their therapy. And then ultimately, there was decreased use of non-beneficial treatment, so people were less likely to kind of get treatment past the point when it was helpful. And then it did help people live longer. And that was a big finding because everybody expected that if you started to focus on quality of life, what if you just, you know, were too focused on quality of life and you weren't focused on quantity of life? And there was, you know, maybe if you started attending to these things, people would come off treatment sooner and they wouldn't live as long. And so the fact that people not only lived as long, they lived longer when they got this specialized attention was a finding that was heard around the world and really launched palliative care and the idea of early palliative care in the clinic in a big way. And so this trial and a couple of others that happened right around the same time led to the American Society of Clinical Oncology, ASCO, developing a guideline. And that guideline says that every patient with advanced cancer, not just advanced lung cancer, but any advanced cancer, should have palliative care from the time of diagnosis routinely through the balance of their lives. And we don't have that right now. There's no question that that doesn't happen for everyone. And that reflects, I think, a huge kind of workforce shortage and a huge issue with regard to reimbursement and then the stigma that we were just talking about. But that is the gold standard on the basis of this study and others. And I think a lot of hesitation persists, but these are the data. And now we're in a different kind of interesting place where cancer treatment is evolving and the experience of people with advanced lung cancer is evolving. So I think if this study were repeated right now, it would be different because at this point, you know, when this study was conducted, the life expectancy of somebody with stage 4 lung cancer was less than a year. And so that kind of palliative care monthly from diagnosis through the end of life might have been, you know, meeting the palliative care doctor 8 times, whereas, you know, we continue to conduct early palliative care studies. We continue to enroll people with lung cancer. And so sometimes I'll have people with lung cancer who I've been seeing for like 5 years, which is fantastic. And I really enjoy getting to know my patients over such a long period of time. But the things that we talk about are totally different than if you were on a trajectory of an 8-month course with advanced lung cancer. So that's sort of what launched my research career, is trying to figure out how to kind of advance our palliative care approach to match the experience of patients living longer and uncertain trajectories of cancer. So yeah, this is just to say all those studies and those guidelines meant that palliative care moved upstream. So from the time of diagnosis, rather than having this like all on and then all focus on cancer care and then focus on hospice, now we kind of think of this idea of like early palliative care that might kind of ebb and flow as somebody has a hospitalization or a progression or maybe a period of stability. And I would say that sometimes, you know, probably what's absent here is like long plateaus of good stability. I might modify this image now, but then, you know, I always say my new slogan about palliative care is that if palliative care was the alphabet, hospice is the letter Z, because, you know, hospice is all palliative care all the time, like all quality of life focused care. So hospice is still within the part of what we do, but it's for when somebody has, you know, in a clinician's best estimate, 6 months that we expect that they'll be here. And so that's when they're eligible for hospice. But then palliative care kind of continues even into the bereavement phase. This is a slightly better image and meant to say that we're, alongside curative intent care from the time of diagnosis. That's the gold standard, at least. And I think that when done right, palliative care can really address some of the broken aspects of healthcare. I think it's no secret that we are in a time where the healthcare system, it can be really hard. People go to the doctor for their kidneys, and then they go to the doctor for their joints, and then they go to the doctor for their cancer, and they see their primary care doctor. And it's hard to find a place where you can just be thought about as a whole person. And have time to really focus on how something huge like cancer has impacted your life. And again, that's another reason why this is a part of my job that I love, is trying to think about people as whole people instead of like thinking about them by organ system. But this is another way of just depicting some of the things that we focus on and the things that we address in palliative care. I like this analogy if you haven't seen this before. It's an analogy about late versus early palliative care. And on the top, it's like the standard idea of a late palliative care referral. This couple is meeting with the doctor. They're learning about their cancer and what might happen. Later, they get caught in the rain. Somebody comes running after them with an umbrella and says, here, this will help. The palliative care is the umbrella in this case. Like, oh, they're in the rain. And they're like, okay, you're having symptoms. Here, have this umbrella. Thanks, I wish we had this earlier. And in the second in the second strip, it's like, okay, you're meeting with the doctor early on. You may not need this yet, but just in case, here's an umbrella. And then the rain comes and they put up their umbrella and then they're like, so glad we had this when we needed it. And I like that. I think thinking about having your palliative care umbrella. And sometimes this is like having a medication that's right on hand and you know how to use it. Sometimes this is having a relationship so you have somebody to call. Sometimes this is having coping strategies to deal with what might be coming your way. Like there's any number of things that this umbrella might represent. But we try and really think about these things upstream. And I love the idea. I love getting to know my patients early on. My first question, honestly, is often just tell me about yourself. Like, tell me about what's important to you. Tell me about your family. Tell me about what you were up to before all this started. Tell me what it's like since this started, just to get to know people so that we don't, get 6 visits in and then be like, oh, you have a dog? Oh, like I didn't know, like we talk about it right up front so that we're familiar with each other. And then, as things change, we know what's important to people. This is another great one. I don't think I can do this one in the slideshow, but maybe I can drop the link in the chat if you haven't seen it. It's the "We're the fire department, not the fire" video. And it's basically like, somebody calls the palliative care doctor. They're like, the house is on fire. Can you go in there and talk with the family? But please, please don't use the word fire. And they're like, we're the fire department. We're here to put out fires. You don't want me to talk about the fire? No, 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 don't talk about the fire. And it's like, I think this goes back to the idea of a lot of people worry that if you refer someone to palliative care, or you say like, oh, it's time to see palliative care, it's like there's something that means, that brings with it about what might be happening with someone. And we're the fire department, not the fire. Like if there's something going on, and I would say a diagnosis is something that's going on, there may be things that we can do to help. Sometimes I'll see people, we get to a great solid place, and then we're like, you know what? We don't have to see each other for 6 months. Or like, just you keep my name, you keep my number, you reach out to me when you need me, but we know each other now. And then I'll get some out of the blue reconnections, or maybe the oncologist will say to me, hey, like you met this person 2 years ago, can you check back in with them now? And then we start off at like a different place, and that's great. But yeah, we're the fire department, not the fire. I like this video. As you all are aware, since the time that we had that palliative care study, like I was saying, we're in a totally new era of cancer treatment. This looks all the way back to, surgical treatments being the main option, then radiotherapy, and then chemotherapy coming in the 1940s, but really targeted therapy, obviously for lung cancer was more like 2010s, but the first targeted therapies we had for, estrogen, breast cancer, and some lymphomas and things was in the 80s and 90s. But then Yeah, really just such an explosion of treatments in the last decade or two, with checkpoint inhibitors also coming online. I drew this little thing about CAR T-cell therapy because that's another one. Just everything is changing so much for cancer treatment, and it's such a wonderful and incredibly hopeful thing. And it means that the experience of people living with cancer is totally different. And so we have to just keep evolving. And so with the kind of improved survival that people have, and there's also new side effects that people have from immunotherapies and targeted therapies. And, we always hear about these better tolerated treatments, or, these and yet there's a lot that people are dealing with all the time. And so sometimes there can be side effects that catch people off guard because of how expectations are set about how much easier these drugs are than chemotherapy. So I think that's important to acknowledge. But often people, as opposed to when we were in the era of chemotherapy as our mainstay of cancer treatment, a lot of times people can get back to their usual activities in a way that they couldn't previously, and that's an incredibly wonderful thing. And they may have things hanging over their head too, like when will this change? When's the other shoe going to drop? And I'll just say, oops, went a little bit too fast there. Cancer-directed treatment is just one part of the puzzle. So these things have been all helpful, but then as I was mentioning before, there's symptoms, there's side effects, there's emotions, there's how cancer affects relationships, and there's illness understanding. So I think that I want to argue that there's still absolutely a role for palliative care, even when we have better tolerated treatments that are helping people live longer. And so this is what I study, actually. I do research. My initial research was descriptive research to try and learn what the experiences are of people living with cancer in the precision oncology and immunotherapy era, and learn about their experience with the communication and understanding about what to expect, and about treatment side effects and how to prepare for those, the experience of living with uncertainty, and what people perceive to be their supportive care needs now that things are different. Acknowledging again just the new toxicities. This is a picture about immunotherapy, how it can cause side effects on kind of any part of the body. CAR T toxicities are wild. I mean, there are a lot more immunotherapies coming online all the time. I know less so for people with targetable mutations with lung cancer, but still an important thing that's changing. And then the biologic therapies, and then the idea of cumulative toxicity, which I haven't even mentioned yet, but just this idea that people are on these treatments that are studied for, some number of months, and then now we give people on them for many years. And so just, we don't really have ways of continuing to study and understand what the impact is of these longer term treatments with therapy. And often I think people feel the effect of that kind of being out there on their own without a huge wealth of data to support management of cumulative toxicities. You guys have probably seen this slide from Jill. It's awesome. I love this slide because it's like, oh, she looks great. And that's how people will perceive that she feels. And then how she actually feels is like, here's all these things that are happening that are under the surface. And this idea that tolerability is relative, that, you never know what's going on with somebody and all the things that they may be experiencing related to their cancer or their cancer treatment. And so you absolutely can't take how somebody looks on the surface to mean that everything is going fine. I'm just going to share a little bit from one of the research studies that we did to learn about communication, about what to expect. So we talked with patients and oncologists, and we also audio recorded visits between patients and oncologists. And these was among people with lung cancer with targetable mutations. And what we wanted to learn about was how oncologists were presenting this kind of new kind of cancer treatment, just to say, how are people's expectations being set? And then how does that sort of affect how they're thinking about what to expect, and what are some opportunities, I think, for supporting illness understanding. And so this idea that came through a lot, my oncologist explained that this is not a death sentence. It's a long-term managed disease. There's medications and treatments. So this idea of transformation from a life-limiting kind of illness to a long-term kind of living with cancer as a chronic disease. And I think that that's a real hallmark and thing that a lot of people can identify with. And then we learned that oncologists, a lot of the things that we had been sort of advocating for with early palliative care, the idea of talking about goals and values early on. People might not be ready to talk about those things yet. And the oncologist mentions this uncertainty about how much things are changing. And so this oncologist mentions the landscape is changing and shifting so quickly that a conversation you had 3 months ago could be completely different because there's a new approved therapy that's doing very, very well. And so that idea of being able to plan a little bit for the future, there's always this huge question mark, and that can be uncomfortable with the uncertainty, but also can be so, so hopeful to be like, there could be something coming. And so you don't want to make major decisions or changes because what if this, I know this isn't a long-term solution. I know that this isn't a cure, but maybe a cure is coming around the corner. But we found in their study too, that it meant that a lot of people were curious about what to expect from their cancer and felt like there was more information that they could have been talking about with their oncologists. People had curiosity about, their life expectancy, but also just about how things would change. And we did notice that oncologists really focused, and especially in their initial conversations with patients, on the really hopeful outcomes, and gave anecdotes and stories about the most helpful patient experiences. So one patient said, my oncologist said there's some patients that have been on this targeted therapy for 10 years and are still doing well. It's not a cure. At some point it will start working, but she didn't say the average. All she talked about it was the person that was on it for 10 years. And I think for people who have a shorter course, it can be super disappointing to have that expectation of living with cancer as a chronic disease and then having things change and realizing that things weren't exactly as promised. I think a huge piece of what we noticed in this study was that people really felt this uncertainty in every aspect of their lives. Like I said, there was this quote about hope, like where there's uncertainty, there's hope. We don't know how long this treatment's going to last because I don't know how long there's hope it's going to be a long time, but there's also fear it won't last long or work, but there's still hope. Going back and forth between, hope and worry, and all in the same statement. We also found that people had, especially earlier, I think, in the course of their illness, but just this feeling of thinking about living and dying every day, enjoying the moment, but in the back of your head, planning not to be there the next time this moment happens, or having questions about working. I'm too young to retire, but do I want to work until I'm too sick to work and then be real sick, or do I maybe want to work less and figure out how to live on a smaller paycheck and have more time? Caregivers in this study also said, life isn't the same, even though she's the one dealing with it. It's a part of me that I feel has been lost as a function of just not being able to see the future. When we asked patients what they wanted in terms of support for living well in this state of kind of uncertainty and, potentially longer trajectories, but certainly uncertain trajectories of advanced cancer, one patient said, I think there's a clear need for a more true integrative support system, not just to say there's these resources available, but say we view having the therapist or social worker, having a team of people who are specialized and see this duality and know how hard it is because people are hurting, even if they're doing fine medically and the doctors don't really address it. This was something we also heard, like the scan looks good, or I look good, or, I'm in a better place, I'm really stable, but I still have a lot of stuff that I'm dealing with. And maybe it's that coping with uncertainty piece. A lot of people told us that they wanted connection to their peers. They wanted to know stories about other people who were going through what they were going through. What surprised me when I did this study, like planning to learn about illness understanding and helping people learn about prognosis, people were like, I want to know about nutrition. I want to know about how I can take control of my health, and I want to know how I can exercise because nobody talks about it. It's like, okay, exercise for helping with fatigue, but like there's no studies that show if it's safe. I mean, our usual way of talking about nutrition and exercise in advanced lung cancer was like, eat as much as you can, just eat, keep the weight on, it would be like, exercise, just like take it easy, or like, do what you feel, exercise is tolerated. Like it wouldn't be like, and now I have patients who are really physically active. They're, getting back to their lives. They're feeling well and able to do it. And others who are not. I mean, I don't want to say that that's everyone. But for some people, this can be a real way to cope. And I found that there was a huge kind of hunger for that as a strategy, not just for coping, obviously, but for just overall health and just trying to live as long and well as possible. And we found that people also wanted educational resources. So you can see this list is like a little different from what I first showed you about the palliative care traditional focus, because it was like, I think so often we're thinking about symptoms. I think symptoms predominate when we're thinking about things, but then when symptoms are under better control because cancer is under better control, or side effects are less of a focus if they've gotten under to a better place, some of these other things become more relevant. And I think of them as like other ways that people's identity has been affected that they don't necessarily have a home for in the medical system. And sometimes, like very often, very, very often, I'm referring a lot. Like I'm not a nutritionist, I'm not a physical therapist, but I might be like, oh, you know what? Go meet with my colleague, or like, maybe a connection to an advocacy group is what you need to have a peer. I'll frequently refer people for connecting with peers, or going to a conference, going to a webinar to learn more, joining a forum. But finding educational resources is also big. So yeah, these were some of the things we learned about from patients. And it started really to sound to me like aspects of survivorship. And so I've been thinking a lot about this term of survivorship and what does it mean. Survivorship, clinical care, so survivorship care is, I think, what's depicted mostly in this diagnosis. And just to take a step back and say the concept of survivorship is like, anyone from the time of diagnosis through the balance of life as a cancer survivor, right? And survivorship is like any impact on cancer on your life in general and living with cancer. But when we talk in the medical field about survivorship care, I found out that it has this super narrow focus, and people really think about survivorship care mostly being for people with early stage cancer who have completed definitive therapy, like, they've gotten chemo or surgery to deal with or radiation, and then they're cured of their cancer, and then they get this kind of survivorship treatment to sort of monitor. And so this idea of kind of acute survivorship, going through treatment and then ending treatment and being extended survivorship and permanent survivorship. And I think that there may be some people for whom this is really relevant, but it certainly doesn't fit with people with advanced cancer who are, not going from cancer diagnosis to treatment to death, or they're having a long survivorship period with survivorship needs, but then they're not having cancer in the rearview mirror. And so we have to sort of rethink how survivorship care might look. There's been an update to the concept of survivorship to sort of acknowledge that some people are diagnosed with early stage cancer and treated with curative intent treatment. Some people are diagnosed with advanced or metastatic cancer or progress to metastatic cancer, and the goal of their care may be to treat to prolong life. And then there are people, and then at some point, people progress to advanced cancer, or to end stage cancer. And this is, I think, where, hospice is most relevant. But thinking about what palliative care looks like, thinking about what supportive care, what survivorship care, it sort of starts to blur together for people who are living with advanced or metastatic cancer in our kind of current era of cancer treatment. And so now we're starting to think about, what does clinical supportive care look like for this population? Yeah, and so survivorship is interesting because survivorship care is not as well defined yet as palliative care, but it's the idea of the management of later long-term side effects, psychosocial support. Cancer surveillance is a big part of survivorship care, care coordination, and cancer surveillance just means like looking for cancer recurrence or new secondary cancers, and health promotion through behavioral change. And then this is acknowledging again that an individual is a survivor from the time of diagnosis through the balance of life. And that there's many kinds of survivors. But I think we're at a point where we need a kind of continuum of patient-centered care, that there's somewhere between survivorship care, the idea of thinking about how to help people just really maximize their health and optimize their health through behavioral change, through nutrition, through physical activity, through, management of health-related behaviors, through psychosocial support. And there's a kind of getting to be a place of overlap with our idea of early integrated palliative care, where we focus on psychosocial support and helping people live well. So that's the area I'm most interested in now, trying to figure out just what that care looks like, who delivers it, and how to help people have access to supportive care. throughout their trajectory of dealing with cancer. And that's actually all the slides that I have. I am going to stop my share because I think I see that there are some things in the chat and I haven't been able to see them. But I am really happy to take questions.
Go ahead, Sever.
Oh, this was great. Thank you so much. Mark, you had a question come in prior to the talk about pain
Sure.
management. Do you want to talk?
Pain management, when you talk about different areas of the body, a person asked about bone mets versus other metastasis in the body. Is there different medications you prescribe for bone mets? And we had a question about thoracic pain. So
Yeah, we have a lot of different approaches to pain, to be honest. So there's sort of ways of classifying the types of pain. So there's inflammatory pain, there's neuropathic pain, there's nociceptive pain. And so bone pain tends to involve a lot of inflammation. And so if somebody has bone pain, we tend to think about non-steroidal anti-inflammatories, sometimes steroids. And so if we can get away with things like ibuprofen to start or NSAIDs, we often will use those to manage pain, whereas neuropathic pain, related to chemotherapy or, radiation of pain along a nerve from, a tumor pressing on a nerve, for example, we'll use certain types of medications that are specific for neuropathic pain. But we also use medications, in addition to using neuropathic pain medications, inflammatory pain medications, and then opioids, which hit all of those types of pain. I think of opioids as being kind of the final common denominator because they do, we'll sometimes use them in combination to get some of these other aspects, but opioids are sort of like our strongest pain medication. And so we're really careful and judicious in how we use them because of the balance of risks and benefits with opioids. But
so you start with over the counter and then you work your way up.
it
So
depends.
depending on the patient itself, or
Sometimes we are starting with opioids if somebody is in severe pain or in a pain
do
crisis.
you need some brands on that, by the way?
Brands, I'm not
Yeah,
gonna
like, or just like names or things
of
that people
opioid
can ask.
medication.
Yeah, yeah.
Yeah, the opioids are morphine, oxycodone, hydromorphone, and then fentanyl and methadone. Those are the opioid medications that
So when
we
you talk about oxycodone, you're talking about like a Percocet has, a certain percentage plus Tylenol, and
use.
so can you explain that a little bit to us?
Sure, absolutely. So when we reach for opioid medications, it's really interesting. Opioids have been through, we're talking about all these different revolutions. The revolution in palliative care, the revolution in cancer treatment. I would say opioids have also been through their own revolution, even in the time that I've been in medicine, which is not that long, but I don't know, 15 years or so. And so when I first started in residency, managing people in my primary care clinic, I had a lot of patients with chronic back pain who were on opioids. And then, even over the course of that time, we were getting people off of opioids. Like there was this whole period of time when pain was a vital sign and we were using opioids really liberally, and then a huge kind of pulling back on using opioids. And I would say that cancer-related pain is kind of is spared from that in a big way. Like it's an area of medicine where we still pretty liberally use opioids for pain to try and help with quality of life. And we try and use the least amount possible. We try and be safe and careful about it. But if somebody is having severe cancer-related pain, opioids can often be really helpful. I tend not to use combination products as much, only because I usually separate the acetaminophen and the full opioid, but they are something that is accessible, and I think that it's fine to use them. Just I'll often use them just to try and monitor the amount of acetaminophen that somebody is getting, because you have to be careful about it. But
So I'm sure you know this, but our TKIs affect the liver, and some people have high AST, ALT, CPK levels. Does any of those medications affect the liver at all, or?
So opioid medications are like often metabolized by the liver, but we often will just sort of monitor how somebody's liver is doing. Usually having liver inflammation doesn't mean that their ability to process medications through the liver is affected. So Tylenol is something we would probably put aside because of the liver risk from that medicine if somebody was experiencing liver inflammation, but opioids, we would probably just select a different opioid if somebody was having severe cancer-related pain and also had liver dysfunction. Same with
And I just
critical
want to,
condition.
yeah, I just want to follow up with some of your slides, which, 10 years ago, like when you heard the word palliative care, you knew hospice was the next word coming out of their mouth. But obviously, your presentation totally debunked that whole issue. So I personally saw a palliative care doctor a year and a half ago, and I was shocked by like, oh my God, why didn't I jump into this earlier? So how do you recommend? Do we get referrals to palliative care doctors? Is there a shortage of palliative care doctors? I know you're an MGH, which is a big center. If you're in a country hospital, how do you get to a palliative care doctor? Can you give a little bit of background of that?
Absolutely. So I would say one of the reasons that people don't get palliative care as often as they should is because there's a gatekeeping effect from oncologists who might think, oh, it isn't time for palliative care. They have the same misconceptions that the general public does often, like, oh, I'll call palliative care. Even in my own institution where we had that big study and like we're all friends, like we all know each other and I've taken care of so many of people's patients and they know what I do and they know that it's appropriate early. I still sometimes will get referrals and be like, oh, this person needs to go on hospice. Like you thought of me like a week before the person is like very close to the end of life. And um, but I will say, so it's education, education, education. But if a patient asks for it, the oncologist will definitely refer. Like that is something that I think people can definitely ask. And we have a website, getpalliativecare.org, that has a directory where you can find a palliative care doctor. A lot of places have palliative care doctors in the hospital. The palliative care doctors in the hospital are frequently helping with putting out fires when people are having a pain crisis, having a major like transition in their life or a major decision-making point, and they do a wonderful and important service. The palliative care that I'm referring to with early palliative care is palliative care in the clinic. That's just like you see them in the clinic, ideally on the same, at the same visit when you're coming to see the oncologist, or we do a lot of telehealth now. I didn't mention, but we had this huge telehealth study that I was a part of from MGH that was an ASCO plenary last year, which was super exciting. My colleague Joe presented it, and we found that palliative care delivered via telehealth was just as effective as palliative care delivered in the clinic. Excuse me, but palliative care in the clinic is the kind of early palliative care idea. And it's not just in cancer centers. Most NCI cancer centers do have a palliative care clinic now, but actually this is going to be like frustrating to hear, but sometimes it's hospices that'll offer home-based palliative care services. So they will offer palliative care consultation and be able to provide recommendations around symptom management or coping, but they're offered through a hospice agency. So that can be one of the ways that people can access it, and particularly in areas that are away from NCI centers. Although I will say, I would imagine that most people who have ALK lung cancer are probably going to a special center to try and find someone with that expertise, or at least for a second opinion. But I don't know.
So,
You correct me.
so let's stay on ALK lung cancer, right? Which you're very familiar with, and with the other oncogenes. So when you look at a patient who's on alectinib, let's say, do you know that patient and what their side effects might be? Because we had a chat question in there about, like, do we all have the same side effects? And my answer would be no, we don't all have the same side effects. But what do you do when you have a patient who's coming in, you look at their background, does that give you a clue of maybe some of their problems or?
Yeah, I think that I will definitely review the treatment and the typical side effects and ask people questions because they might not even connect that something that they're dealing with relates to their cancer treatment. And then I'm working in close conjunction with the oncology team. And sometimes they've already tried a lot of things with their oncology team, and then we're thinking about the kitchen sink together to try and figure out what to do. Or sometimes I'm um, talking with the oncology team about dose adjustment, because that can be a really helpful thing for managing side effects. And it can be something that people are worried about talking about with our oncology team, but they might feel safer to talk about it because of and the impacts on quality of life. And so kind of talking through that, like I always present to patients and their families that I'm working in close concert with the oncology team. So not to say that I'm like, I if I'm going to share information with the oncology team that a patient shared with me, I let the patient know, like, oh, would it be okay if I shared this with your team so that, if there's an adjustment to be made, we can talk about it as a possibility. Because sometimes people just don't even know. And sometimes oncologists honestly don't know that dose adjustments can happen. And people like kind of suffer on a high dose when they don't necessarily have to. They could get a cancer treatment effect at a lower dose with less toxicity.
So that brings two questions. Like, you have the meeting, care partner has to be there, right? You would think.
no,
Someone that,
no,
like,
it's
because
up to
when
the
you or I ask the question, like, hey, how are you doing? Oh, I'm doing good. Because you don't want to sound like a complainer, right? But you have to have, don't you think that's like a team effect where you have to have both parties involved of some sort?
You mean like having a person, their caregiver, or a person?
It's just, yeah, caregiver or someone that lives with them or someone
I
that's been
never
with
brought
them.
anybody to mind. I don't
No,
think
you never
so.
brought anything?
Mm-mm.
Maybe Jeff just
Yeah.
didn't care. What do you think? Sorry.
We support whoever is, there, and we acknowledge that there's often people who aren't there who are important in people's lives. And so sometimes, like, the upshot of our conversation is like, oh, I can tell that, having a loved one here with you would be really helpful to talk through some of the things that you have on your mind. Like, you want to bring your adult child, you want to bring your spouse, bring the person who you talk through these things with. And that is something we do at a future visit. That's happened a lot. And sometimes I definitely have had the experience where, somebody will be give me one version of what's going on, and then I'll get another version from the caregiver. Like, I'm really worried about them because of XYZ. And so we can get a different perspective. But no, I would say everybody can come as they choose to come, and I often too, if I'm going to be like wading into a territory, like for example, conversations about prognosis or like what people are worried about, or conversation about sensitive topics like sexuality, they can just like come up in our visits. But I'll always be like, oh, is there an adult child here? Like, does somebody want to talk about their sexuality in front of their adult child? Probably not. So, I'll kind of check like, oh, are the right people, like, who's in the room, and like what do we want to talk about? And like, is this like the person who has the like ability to totally dictate who's there and what we talk about as the patient. So,
No,
but
those those are great points. Reading the room for sure. I just want to remind everybody too, and how Mark kind of led to this, that it is individualized. Like, you have the backgrounds on our TKIs, you have the notes from their visits, but it's totally individualized. And in the chat, there's a heated discussion right now about Tylenol versus ibuprofen. And again, Dr. Petrillo doesn't know your exact history. So always be sure to talk to your oncologist, to talk to your care team, so that you're getting the right advice for you. Maybe there's something else. I personally take Tylenol and Advil and have never been told that I couldn't take either. But maybe there's a reason that somebody else can't take those.
that's such a good framing, Summer. I think, yeah, I definitely want to personally refrain in this forum from providing any specific medical advice. I definitely recommend kind of talking through, and we do like I review people's charts and histories. I usually talk with the oncology team if I'm prescribing something new, and I do prescribe. I will like run checks to make sure there aren't interactions. Clinical trials is always something where we have to be careful, and just make sure that we're not prescribing a medication that might interfere. So I'll check with the clinical trial pharmacist. And so, yeah. And so, yeah, I would definitely encourage people. And, ibuprofen and acetaminophen just have different sort of roles where they work differently. And so they might be valuable in different settings. There's some really fascinating stuff in the chat. I'm sorry that I wasn't monitoring it. It was like with the slides. Do we want to go back and see if we can capture any more of these?
Yeah. I was going to ask you about energy. Any recommendations for energy? Someone asked any specific vitamins you recommend. Again, I think a lot of that is cross-checking with your history, but if you have any comments on those.
Yeah. So thinking about cancer-related fatigue, when I meet somebody and they're talking about that with me, I'll first sort of review a bunch of things. How have they been sleeping? How's their nutrition? What's their physical activity been like? How have things changed with their strength and conditioning? Then I'll run through their medications. Are they on any medications that might be sedating or being like affecting their energy? A lot of cancer treatments affect energy. Sometimes cancer is the thing that is causing people to have less energy, and sometimes it's pain, sometimes it's depression. So there are so many things that can affect our energy levels. So I think and adrenal insufficiency, there's like so many different things. So we usually will start with a really good history about what's been going on with somebody to see if there's something we can address. I really love to address sleep and just think through sleep habits, sleep medications if necessary. So that's an important one. So that's the first thing we'll sort of review. And then if we want to talk about using medications to help with energy, there aren't great data about it, but we do sort of anecdotally use some medications to help. So if somebody is has kind of cancer-related fatigue, or particularly if they have sedation from medications like opioids, we sometimes will use low-dose stimulants. So things like Ritalin, which the kids use for ADHD, we will use that medication sometimes to help people with cancer-related fatigue. The data aren't great, but anecdotally, I've had people have success and had other people who have not had success. And so you want to be careful if people have a history of arrhythmias, then that's something to be careful about. So always like, again, that point that Summer made was just so excellent. And I want to emphasize it's all individual, so no medical advice being provided here. But just to give an example, we also will treat mood if mood is a component. And then I would say behaviorally, the most important thing that we usually think about is physical activity. And it's not just kind of getting out and exercising and doing 150 minutes a week or whatever that insane standard is from the American College of Sports Medicine. We think about avoiding inactivity as being a really important idea. So we all are living a much more sedentary lifestyle. And, I want to think about, I always am mindful with people who are dealing with advanced cancer that not to come across as kind of finger wagging and be like, you need to be exercising, but rather just to say, if fatigue is something that you're dealing with, finding ways to incorporate more activity into your day can help with having more energy. It's a little bit counterintuitive. A lot of people feel like if they're more active, they might be more tired, but actually like it improves conditioning and it's one of the main things that we actually have to help people feel less fatigued. So physical activity is something that I think is really, really powerful. And, we're only at the beginning, I think, of having good data to show it, but I think it's a really important
It's
piece
such a
of
good point because it's such a double-edged sword,
Totally.
And actually I'd gotten advice from somebody once, like just walk out and walk up and down your driveway, like start small, it's a perfect, I'm gonna be stealing so many little quotes of yours. I'll be
So
sure to give you credit.
we don't have to, yeah, steal
I
away.
love the alphabet, I love the fire, and avoid inactivity. That's such a good way to say it, yeah, because it's so double-edged. Mark, is there anything else that you
I
wanted?
think we need just a takeaway of how to bring in a palliative care doctor into our care team. And don't be afraid of asking and nudging. But does your GP play any role in this, or is it all through your oncology, or how do you do that?
Yeah, a primary care doctor could totally refer, and people can self-refer, if somebody wanted to call and set up a palliative care appointment. I think I did that for one of my family members, just like, they were somewhere in New Jersey and I was like, I found them a palliative care provider from the directory and said, why don't you call and make an appointment? Because I knew that they needed that connection. I could tell from just talking with them that they weren't getting everything they needed from, I don't in any way mean to, disrespect or say anything about the oncologist care. The oncologists perform an incredibly important service, and they're incredibly busy, and they have a really good focus on treating the cancer, and it's plenty, so like we're a team, and so we support each other and work together. So I definitely appreciate the holistic care that my oncology colleagues provide. And we have sometimes more time.
So part two for having you come back is any medical marijuana studies or anything that we could share somewhere down the line about that?
So medical marijuana is really interesting. There's plenty of studies, actually. I think the most data is around pain management, actually, for cancer-related pain. And anecdotally, I've definitely had benefit for pain, like helping people with pain with medical marijuana. I've also had benefit with nausea and appetite. Those are the things that medical marijuana can be really helpful for. But I think one thing I get wary of is I've heard there are some types of medical marijuana, like Rick Simpson oil, that is kind of purporting to slow the cancer growth, and I don't think we have those data. But data for treating symptoms, we do have some data about kind of using the whole plant. I don't use products like Marinol and that just isolate part of the marijuana product, but I do refer really liberally to my colleagues who prescribe medical marijuana. Or in Massachusetts, it's actually legal, so sometimes people will just get recreational marijuana if that's what's easier for them.
Any studies done for palliative care on the new weight loss drugs?
That's exactly what I was just gonna say, something about.
Not
We're
that I
the
don't need it, but I
opposite.
do need it.
No,
We're
it's
begging for GLP-1s over here.
No, I actually have referred some of my patients for like weight management clinics and have had them start on drugs. You know, it's so interesting because I think, like I said, it's totally new territory for us because literally we would be like, eat all the ice cream because, you know, we don't know what's going to happen down the road, or like, you know, just our counseling around nutrition was so different. And now with people in a different phase of with different experiences of cancer, and with some of these drugs that cause weight gain in particular too, you know, I've had patients who had to have a knee surgery, for example, because they have, you know, weight related joint pain. And then anyway, I don't know of any data about GLP-1s and cancer. If you know about them, please let me know. But I will say that we are using them now for people who are dealing with cancer, for people who are on cancer treatment. And I think the considerations are similar of just like, you know, looking for drug interactions, being mindful of side effects. I have had some patients though, kind of tragically, who have been on GLP-1s and then developed cancer and didn't know that they had cancer because they had weight loss. And their initial presenting cancer symptoms were masked for a little while. So I'm curious to know if that's a trend, because I've heard of that a handful of times now. But I think it's something we're going to be seeing more and more and learning more about. I think the main thing just to be mindful of, like in any setting, is just, you know, making sure that everybody on the care team is aware of what's going on, thinking about drug interactions, thinking about coordination. And I wish we were in a system and society where the onus on kind of doing that coordination wasn't on the patient. You know, I wish that we had, you know, and I try and do that for my patients where I can, to do the care coordination, to do the like looking for interactions, to do the referring, to do the talking in between, because we all will see it, you know, I'll see a patient, another specialist will see the patient, and like we won't necessarily talk to each other. So like there's a lot of picking up the phone. But patients, I think, can also do so much for themselves to be kind of paying attention to these things. Although I wish that weren't necessary always, you know, that people have enough going on. But there is so much that can happen when medicine gets so fractionated like this.
And we are living a lot longer on these drugs.
Totally.
And the advancements are incredible.
Incredible.
So obviously we do come across, and like you said on your slideshow, these drugs are so fast tracked through the system. We really don't know the long-term effects of them, you know? So keep on top of your pain management, everyone. And I want to thank you so much for coming on a Sunday with 3 young kids and
Oh,
working
anytime.
your schedule during the week. And Summer, do you have any closing words? Because then next week we'll also have a talk. So
Yes, next week we have Dr. Sharish Gagiel, Mark's oncologist, coming on to talk about the role of chemotherapy. Do you have it to, upon progression, to buy yourself some more time? Do you save it for the end? Some people are using it up front. Symptoms, again, how palliative care plays in to chemo also. So we'll be talking about all things chemo. Thanks, Mark. And Dr. Petrillo, thank you so much. So great to see you again.
Such a pleasure to be here. Thank you very much for having me.
thank you. You guys want to mute and say thank you
Yeah.
to Dr. Petrillo.
Thank you.
Thank you so
Thank you
much.
very much. You're
Thank
really
you
good.
very
much.
Thank you.
Thank you.
Thank
Bye-bye.
you. We
Thank you.
appreciate it.
Thank you.
Thank you.
Thank you. Thank you.
Thank you, Dr.